I'm Ben. For those who don't know me online, I'm a fourth-year neuro resident, and today we'll be talking about beta amyloid and Alzheimer's disease. So just sort of a agenda and overview of what I'll be talking about. I think talk about the recent retraction and controversy regarding a paper, some current overview of the current therapies, some different genetic and population-specific insights, emerging therapies and vaccines, just to touch on a few, kind of very broad to dive into detail on all of them, and then some, future directions and where are we going from here today, and some upcoming studies and approaches. So yeah, I want to start by polling the room. Who here thinks that the deposition of amyloid plaques causes Alzheimer's? Anybody want to take a stand? Yeah, got a few hands. Yeah, few maybe shrug yes. Or is it just merely a signature of the disease, or somewhere in the middle, complexity? Yeah, yeah. Okay, so some comments that tau plays a role too. Okay. Yeah, maybe. Yeah, so I don't know if you guys can hear Dr. Brown online, but maybe the amyloid or use the example of alpha-synuclein plaques are there to protect against something else. Okay. If this will play. Well, bottom right over here. Yeah. Let's see, I'm trying to play this video. Here we go. There we go.
Hypothesis has been that this plaque formed by a precursor protein called amyloid beta accumulates in the brain, and by finding a drug that can potentially extract those plaques from the brain, from the extracellular space around neurons, that we could essentially cure the disease. That the causal factor in the condition was ultimately this amyloid beta protein, which forms the plaque. And trial after trial had been a dismal failure, and it wasn't looking good until in 2006 a paper was published in Nature, which for any scientist publishing in Nature, it's like winning an Academy Award. And that paper, essentially what that did was it allegedly identified this variant of amyloid beta that connected the plaque to the cognitive dysfunction, so the most important clinical feature of Alzheimer's disease. Because for a long time, it was known that cognitively healthy people accumulate plaque in their brains, and that plaque doesn't seem to correlate with cognitive impairment or anything like that. And so that was very deflating for researchers in the field until this 2006 paper came out. And what it did was it renewed faith in this hypothesis, which was always a hypothesis and continued to send billions and billions of dollars worth of funding down this path. And what turned out to be the case just 2 years ago was that that paper was essentially fraudulent.
Yeah, that was from podcast Joe Rogan Experience last summer. So um, the speaker there is Max Lugaver. He's a journalist, but his mom had Alzheimer's, so he talked quite a bit about it. But yeah, that podcast had probably around 11 million views. So. And this is the specific article he was referencing that was retracted. So it was published in 2006 and it wasn't retracted until 2024. So I found that be interesting and kind of went down a little rabbit hole in how that came to be. So essentially, what was called into question was images on the paper of the Western blot and immunoblot that proved existence of this amyloid beta star 56. And per the study, it correlated with memory impairment once it was found in these transgenic mice. And when it was found, it correlated with memory impairment at 6 months, and they found it in every mice in the study, or so they claimed. And then if they had administered that protein to the brains of younger mice, it disrupted their memory. So this is a site, PubPeer. I had never heard of it before this, but maybe some of you guys have. Essentially, it's almost like an online forum of peer review. You can post anonymously. It's moderated, so people have to like accept your comments. And I left the link here because this is where the discussion started on this paper's retraction. So someone was essentially looking very closely at the images from a paper 16 years ago. And here's kind of what they saw. This is the first post that kind of, I think, kicked everything off. It was from Durancum reticulatum, which I think is some sort of plant. But he's pointing at these just kind of horizontal linear lines in the background of the images, and he's saying, hey, essentially that doesn't look right. And then after this initial post, I think kind of people dogpiled on multiple images of the paper and said, hey, what about this figure, this figure, this figure, this figure? And they found, things that shouldn't be there in a lot of these Western blots. And so then, shortly, a few months after that post, Nature, essentially says this with their editor's notes. Say, hey, we're investigating this. And then, in this forum on PubPeer, the lead author is sort of replying to all the comments and criticisms. And what she says here that, some of the images and concern that people posted about, she thinks were from some manuscript processing of the PDF. And she even posted the original images and highlights that, hey, there's none of these linear splice marks here. So, not sure exactly what happened, but here's the original image without that anomaly, or she claims, like artifactual. And then, yeah, here's just an example of one of the lead authors essentially saying, hey, these quote unquote splice marks in the Western blot artifactual, and we don't think it's valid for the criticism of the paper. Here's a post from Elizabeth Bick. She's a PhD in microbiology, but she's pretty well known for detecting photo manipulation in scientific publications. I guess she's identified over like 4,000 potential cases of research misconduct. This one was essentially not artifactual because if you look at these highlighted boxes in pink, it almost looks like an exact copy left to right. And sort of the basic scientists in this thread are like, yeah, that shouldn't happen ever. So. And then here's a close up where you can kind of see that these are an exact copy on the Western blot on the left and right. Yeah. Dr. Brown said, who has the time? Okay, so yeah, after the criticism of the images starts, Karen Ash attempts to reproduce the results. I guess she feels like, okay, this is going to get some heat. Let's just reproduce and, publish a correction was kind of her stance. And then there's some input from other individuals in the thread. Dr. Schrag, is a neurologist and PhD as well at Vanderbilt. This is essentially what he said that, um, that he was still persistently doubting the existence of this amyloid beta star 56 because in the reproduced study that only 15% of the mice had that at onset of memory impairment. So Karen Ash kind of addressed different criticisms he made about images and image processing, and people kind of debated, what essentially what needs to be done to assess fraudulent images in papers and come up with standards, but didn't really address the lack of the amyloid beta star 56 compared to the initial paper. So I think kind of conceded that point. But then, in the same forum, she updated the pub peer community that she was going to concede and retract the paper. But she still kind of stood her ground that she believes that it could play the amyloid beta star 56 oligomer could play an important role in Alzheimer's disease and thought that targeting its removal was beneficial. And then she also says, that she had no knowledge of the image manipulation until somebody looked at it 16 years later and said, hey, that looks funny. So, and here's a link to her study at attempting to replicate the results. I can share this with you guys if you have any interest in reading it. So this kind of brings us back to our current situation. We have people in popular media kind of saying, hey, this article is retracted, amyloid hypothesis. What are we doing with that? And then we have, our current FDA approved, I say disease modifying in quotes because, even if you accept the efficacy of, a 20 to 30% reduction in worsening, then people question how worth it is that, given some of the risks as well. And should we continue to search for more efficacious anti-amyloid therapies? So now I just want to pull the room. What are some good arguments for the amyloid hypothesis? Yeah. Yeah. Dr. Gentry is talking about post-mortem analysis criteria for diagnosing the disease to have amyloid and tau. Anything else? I think some other ones, some mutations in genes related to amyloid production. amyloid precursor protein and trisomy 21. So, and then I'll talk further about ApoE4 allele and what amyloid looks like in that population, heterozygotes and homozygotes. And then what are some arguments against amyloid hypothesis? Yeah, and Dr. Gentry talked about, plaque burden doesn't correlate without disease severity, or, there's cognitively unimpaired people with plaque as well. Yeah. So then revisiting the treatment mechanism of action. I think targeting a plaque, we often think it's been going on sometimes a decade or more before it causes symptoms. And then you want to remove that plaque over a couple years and expect a big change. I don't think I would expect a big change with that sort of approach. But then we still see potentially a 20 to 30% reduction in the rate of decline with these new studies. So why are those working? And then also, why is atrophy occurring in these treatments? And then I think another sort of problem with the new therapies is, um, this is on the up-to-date page for lecanemab. We do not treat such patients with ApoE4 homozygosity. Probably because the greatest risk of amyloid-related imaging abnormalities. Although some centers will still do this. But I would say those populations probably have the most to gain from an anti-amyloid therapy. So you're just mentioning amyloid burden in ApoE or homozygous individuals. Um, yeah, they have higher Alzheimer's biomarkers at age 55 compared to ApoE3 with CSF plasma tau and plasma tau concentrations. Um, and then by age 65, almost all ApoE homozygotes have abnormal amyloid in their CSF, and 75% have amyloid in their brain imaging. And then if they're going to be 85 years old, 60% chance of developing Alzheimer's disease by then. And then visual scintilloid scores, that's based on PET scan, have increases compared to other ApoE3 or 2 on their visual scintilloid scores. So yeah, I would think that this population would have potentially most to benefit from anti-amyloid therapies, but we're not giving lecanemab, or some of them aren't because of risk of harm, and probably from removing more amyloid and causing more problems. Then kind of reconsider the current approach. And then talked about this with some of us. Not all homozygous ApoE4 carriers have the same Alzheimer's risk. In Nigerian Yoruban population, there's no association with ApoE4 alleles and getting Alzheimer's. Further research, I think, probably protective. There's other genes that are protective. Somebody discovered this single nucleotide polymorphism near ApoE and can reduce the risk. It might be that. There's also genetic lifestyle factors. And then, another potential problem I have is if amyloid accumulation is causal for cognitive impairment in Alzheimer's disease, why do we want to wait for it to accumulate before we start trying to remove it or address it? Like in it trying to remove a bomb after it's already blown up or defuse it after it's exploded. Um, but but still, there's you know, with these new agents, there's still a 30% reduction in the rate of decline, um, which I would think it's more from you're quickly removing new beta amyloid that's deposited, which leads to less tau, less cognitive impairment over time. Although this effect may be modest, as we know. So then other therapies, there's been plenty of trials of vaccines. This was near my med school, and Southwestern was like an hour away. So knew about this back in 2018. It's kind of a press release article, and they said, "Hey, we're gonna start testing soon." And that was back in 2018, and I haven't seen any publications from them. So I think might be some difficulty with enrollment. And is that even a good idea? And are there any problems with using the immune system to attack proteins in the brain? Um, yeah, it looks like there was back in Alzheimer's trial. This was the AN 1792 trial. It was more than 20 years ago. 6% of the study volunteers developed meningoencephalitis. Some got better, but some had permanent dysfunction from this. Um, and the researchers in that study hypothesized that it might have been based on T cell and microglial activation that may have been responsible. So that search to develop safer vaccines that didn't have that property. So this is one it's been given in humans, not yet in the U.S. For the last more than 10 years, actually. Um, and yeah, it's essentially it's found to be safe, well tolerated, and generated a robust immune response with the antibodies found. But it also led to findings of amyloid-related imaging abnormalities. I think maybe, hey, is it working similar to the current infusions we have? Here's another potential, call it a vaccine. It's usually using intranasal immune modulator proteolin. Also been recruiting since 2021, or they said, hey, we're going to do this, and I haven't seen any data or anything that we've started yet, so also might be difficulty in recruiting. This was thought to use toll-like receptors for clearing amyloid, or hypothesis essentially. And are the vaccines even a different enough approach? I'd say they could be, but if you're still enrolling individuals at the current stage that you're treating other amyloid or Alzheimer's patients, then might also be late and only expect to see, again, a mild or modest benefit. This is just a highlight of a site. It's Alz Forum. You can kind of organize all the current drug trials by every therapeutic, by what phase they're in, what they're seeking to address, mechanism of action. I found it useful for um, sort of sorting through research more quickly on this. So then on some pharmacogenomically targeted therapies, I'm going to talk about homotaurine, also known as tremiprosate. Essentially, this was studied a while ago and phase 3, and then it failed essentially. Um, and then the company Neurochem essentially marketed homotaurine as a supplement after that and was just selling it. And then years later, somebody went back and did a subgroup analysis and said, hey, we're seeing a positive effect in individuals with two ApoE4 copies. Thought mechanism is decreased aggregation of amyloid beta 42. And then, homotaurine is next to taurine. We have some taurine in the room here currently. um, and here's taurine, homotaurine, which was the trimethoprim, and here's ALZ 801, which is a prodrug, which is thought to get higher levels of the drug into the brain. So they looked at this, a phase 2 study. They started this prodrug and found that it decreased plasma tau, ratio of p-tau 181, amyloid beta 42, and then also found some improvement on a Ray auditory verbal learning test. But it wasn't placebo controlled, but it did find that it was slowing hippocampal atrophy across the study, which I think is pretty promising. But then checked in, and I will mention actually the phase 2, it was either one heterozygotes of ApoE4 or homozygotes. But then the phase 3 trial, Apollo E4, looked at just ApoE4 homozygotes. But they didn't find any difference on cognitive testing. ADAS-Cog13 is what they used. But it did preserve hippocampal volume and cortical thickness in the group as a whole. And then it seems like individuals who were least affected, the mild cognitive impairment subgroup, had a more significant effect in reduction in atrophy. And it was also, safe, no area E or area H compared to placebo. Yeah, and then going back to taurine, its own feels recognized as safe in drinks. And also there are only kind of quality human study on taurine. It's other than homotaurine, and what we're seeing the prodrug was that it can lower blood pressure and improve vascular function and pre-hypertension. Pre-hypertension is like a systolic blood pressure between 120 and 129, but it lowered systolic blood pressure like 7 points. I think, where do we go from here? Just keep trugging along, doing the same thing, or do you want to give experimental therapies to at-risk individuals? I think that's essentially some of the trials. And, how long can we perform a trial for? It's kind of always going to be a problem with cost. So then, do we want to just try and prevent amyloid accumulating at all? I think is a worthwhile endeavor. But then, what if, you're going to then do a trial on somebody who might have not accumulated amyloid or ever developed Alzheimer's, and then expose them to something for a decade or two, potentially. And yeah, what populations would be most vulnerable for getting Alzheimer's from the day they were born? Talked about this earlier. It would be probably trisomy 21. So they have like a 90% risk of developing Alzheimer's disease. They get their diagnosis around an average age of 54. USC is actually said they were going to do a trial on with donanemab in Down syndrome patients later this year. So I think that's pretty promising. And then there's also Alzheimer biomarkers consortium with Down syndrome that's ongoing. That's looking at a lot of data, essentially. And then so we've talked about some preclinical Alzheimer's studies in Journal Club in the last year. This was one with solanezumab, produced by New England Journal of Medicine in 2023, or published there. So essentially, they took individuals with no cognitive impairment on the clinical dementia rating scale, and then had a mini mental status exam greater than 25, and they had amyloid on their brain and PET. Essentially, they found no difference in amyloid related imaging abnormalities, but they didn't find any difference in rate of dementia or decline as well. Studied, I think, for 4 years as well. So I think, using drugs that have been found to reduce progression 20, 30%, but use those in a preclinical model is probably more promising. So at least it's been shown to do something in certain scenarios. So this is sort of upcoming trials. This is AHEAD 345. Essentially, they're going to, same sort of preclinical, no cognitive impairment, but they have, Centiloid scores based on PET scan of, in one trial, A3, 20 to 40, and A45 greater than 40. But they're going to change the dose of the lecanemab based on which group they fall in and titrate more slowly with the expectation that we could decrease amyloid related imaging abnormalities if that's contributing to cognitive decline as well. And then Trailblazer ALS 3 is a similar approach, but with donanemab. I think those are probably most promising approaches currently with the existing medications. And then I'll pull the room again. I mean, what do you guys think the biggest need in neurology is currently? We probably have broad opinions on that, but fresh legs. Eliminate vascular disease. Right. Yeah, more aggressive prevention of these things. Yeah. Early detection. Yeah. I think, effective treatment for neurodegenerative diseases. That's probably still or the most diagnosed, and not audios, but maybe not able to do as much as we'd like. But ideally, disease modifying would start it and then no progression. But don't always see that happen. So I guess where I stand on the amyloid beta hypothesis currently, I just don't think it's been adequately evaluated. If you're still waiting for it to be deposited for a long time and cause problems before you start treating, or even let it be deposited for a long time, not causing problems yet before you treat it. So I think the earlier treatment, the better, or strategies of preventing its accumulation or aggregation would probably be the most potential to work if it was ever going to work. So I'd like to see that before completely writing off the beta amyloid hypothesis. Any questions, concerns, comments? Okay, chat message. Yeah. Yeah, definitely. Consent. Yeah, it's an at-risk group for Down syndrome, but I think, the goal is probably um, pure and good if, that many of them develop Alzheimer's disease and you want to you want to try something and it's not like you're giving them therapies that have shown efficacy in different populations. So I think that's probably the rationale and how people get around approving that. But I agree with you. Yeah. Through this in, it's my favorite question to ask med students. This was one that was asked to me. Dr. Blair in Fort Worth, Texas. He's at UT Southwestern, but this assignment he gave me, he said, read the Old Testament, David versus Goliath, and then tell me all the neurologic issues Goliath had and how David could win. But you guys are probably all too good at that. You'll know, but there's a lot in there. And then, yeah, some follow-up questions is how did he die from just a rock to the forehead, and why would he fall forward specifically? Why does he need a shield bearer? So that's just look at thought processing and how you think about things. And there's some localization, but yeah, you should ask him all that and put him on the hot seat. All right, anything else?